Okay, we want to finish up talking about Chapter 9, Diseases of the Nervous System, is where we left off. Let's talk a little bit more about spinal cord injury. It's usually a mechanical injury to the spinal cord tissue. The symptoms include loss of sensory and motor function, and obviously the extent of the injury depends on the location. The diagnosis involves a neurological exam along with imaging, and the treatments are um, preventing further injury through immobilization, and the use of steroids is an anti inflammatory intervention. Long term care includes physical therapy, occupational therapy, supportive care, and management of the symptoms. Peripheral neuropathy is damage to the peripheral nerves due to injury or illness. The symptoms include motor and sensory abnormalities, weakness, pain, numbness, and tingling. The diagnosis is imaging, biopsy, and patient history, and the treatments are management of the pain, treatment of the underlying disorder that causes the nerve damage, and there are a lot of modalities that do this. TENS units are one of the frequently used interventions for neuropathy. They interfere with the pain signal coming back to the brain by producing an electrical current that has an analgesic effect. And for pain that is the result of nerve injury itself, where it's not coming from some other disease state, uh, this is one of the recommended modalities. Hydrocephalus is called water on the brain. Uh, Results from excess cerebral spinal fluid in the brain due to either trauma or birth defects. Symptoms vary with age. The skull will expand to attempt to accommodate the extra pressure brought about by the accumulation of fluid. It can cause irritability in babies, irritability in adults, vomiting, seizures, sleepiness, and dementia in older patients due to damage to the nerve tissue. The diagnosis includes imaging and pressure monitoring, and the treatments are to use a shunt in order to relieve the pressure so that we don't crush central nervous system tissue in the brain. And this is something that has to be left in for the rest of the patient's life. Parkinson's disease is progressive loss of dopaminergic neurons in the substantia nigra. Dopamine is a type of neurotransmitter, and the substantia nigra is one of the deep nuclei of the brain. It lies below the cerebral cortex, and it's embedded in that deep white matter, and it aids in the initiation of conscious movement. And when the dopaminergic neurons are incapable of producing the neurotransmitter dopamine, it's difficult to initiate voluntary movement. Symptoms include resting tremor, slow movement, rigidity, and cognitive and emotional disturbance. The diagnosis includes a history, imaging, and a neurological exam. There's no cure, but dopamine enhancing drugs are often used. We treat the symptoms, and we can also use deep brain stimulation in some cases. And we did touch on the fact that to, to say there's no treatment isn't entirely true. There is a treatment for this condition, but the material that would have to be used in order to treat it isn't something that we can acquire here in the United States legally. It would come from the brain tissue of aborted fetuses, and these would be dopaminergic stem cells. It's been shown that in some cases they can repopulate the damaged area and restore some of the pre-Parkinsonian functionality to the brain. We have attempted similar treatments using stem cells from the adrenal medulla and have had some success, although it's been limited. This usually involves culturing those cells and tricking them into becoming dopaminergic neurons. And as I said, it's had limited success in some of the early trials. ALS, or Lou Gehrig's disease, is a progressive loss of motor neurons in the central and peripheral nervous system due to causes that we don't fully understand yet. The symptoms include progressive muscle weakness, twitching and cramping, and eventually leading to complete paralysis. The sensation is generally normal. There's no definitive diagnosis, but the presence of flaccid and spastic paralysis indicates the presence of ALS. We also attempt to rule out other disorders. When we say flaccid paralysis, what we mean is that the individual is incapable of movement, but there's no musculoskeletal rigidity. Spastic paralysis would be paralysis with rigidity. The treatments, well, there's no cure, but there are drugs that can slow the progression, and we can also manage the symptoms. Alzheimer's disease we don't know the cause. It's believed to be a buildup of plaque in the brain, and it could also involve a defect in neurotransmission. Symptoms are varying degrees of confusion, memory loss, cognitive defects, and personality changes. We diagnose it with a history and a physical, and we interview the family members, and we perform cognitive testing on the individual. That's basically to see what their level of awareness is and whether or not this has affected their day-to-day functioning. There's no cure. Drug therapy can prevent or decrease some of the symptoms in early to middle stages of disease. Okay, the next thing we want to look at is a little bit of bipolar disorder, followed by some obsessive compulsive disorder or OCD, and we'll then look at schizophrenia, and then I'll rejoin you in a brief discussion about some of the drugs used to treat some of these illnesses.
When was the first time you noticed that something wasn't right, that you were experiencing?
I was about 14.
14? What happened? Can you tell us about that?
My uncle had just died, and I was hallucinating. I was seeing, it wasn't a real something in front of me that I saw. It was the things that were going on around me were not what was really happening.
So he had just died, and the first thing you noticed was something strange.
Things were out of focus. My brother was sitting. We have a strange family to begin with, but my brother was sitting there eating watermelon, and I was thinking he was eating blood because it looked like blood to me.
Okay.
And I got very upset and very scared, and he's got some real pointed incisors, and I was thinking he was a vampire. I was really...
So you thought he was a vampire and he was eating blood? And
I was really scared.
You were very scared.
My mom came home, and she said, "What's going on?" And I told her he beat me up, and she didn't know what to do. She knew that something was wrong, but she didn't have any idea of what to do or what exactly was going on. And I was out for like 3 or 4 days. Just walking around doing things, but I wasn't able to, I can't remember. My dad was renting a storefront to make tacos to sell. It wasn't a fantasy of his. He wanted to do that. He'd wanted to do it all his life, and he finally rented the place, and he was getting ready to do it. The situation was all wrong. It was all backwards. My brother was there, my dad and my grandpa were there. They were the 3 people that were supposed to be, well, I wasn't really young, but with the illness you need someone to watch what you do. Well, they were supposed to be doing that, but they didn't. And I didn't eat for like 3 weeks. And nobody questioned or checked.
Why did you stop eating?
I guess in the back of my mind, in my subconscious, I had decided that I wasn't going to do this anymore. That I wasn't going to be involved with my dad, that I wasn't going to live this way, that my dad wasn't going to have control over me anymore, that I wasn't going to put up with it, that I was going to either die or I just wouldn't do anything. I wasn't going to eat, I wasn't going to sleep, I wasn't going to do nothing. That's it. I'm withdrawing from life. That's the end of it. If you want me to do anything, you've got to treat me right, or else I'm not going to do it. And even if you do treat me right, I still might not do it. And I was very determined that I wasn't going to have anything to do with this life anymore because it was too painful. It was just awful. And I wasn't going to have anything. I stopped talking.
Did you think you would die?
I wasn't thinking about dying. I was more thinking about just getting away from
the pain.
I distanced myself from reality. I start hearing voices. They tell me they're not really just talking to me. They're it kind of they create I call them delusional hallucination.
Okay.
Where I'm thinking that, like I could be talking to someone and all of a sudden I think they're able to fly, or they're not there. They're not really there. Or I'm not really here. Or even now when I hear voices, I think that the person is there talking to me.
Okay.
And I don't see anybody there.
Do you recognize who it is?
Yeah, most of the time it's my family or a friend that I know for a long time.
What kind of a thought would be so distressing to you?
Thoughts about the real big one was cursing at God, because I thought that would be what is sometimes known as the unpardonable sin.
Okay.
And
like you'd imagine yourself doing that, or wonder if you did it?
It was classic OCD. The idea of this would maybe enter my mind. I mean, I would be scared that it would happen, that I would have the thought. But of course, when I wasn't thinking about it, or if my mind was on something else, of course I was okay. But maybe I'd be walking into church, and after living with this fear for a while, probably every time you walk into church, you say, I am not going to let this thought come into my mind. And so you decide to fight it, but the compulsive part of the OCD kicks in, and you get a compulsion to repeat the words or whatever, or the thought, the picture, whether the thought is a word or a picture. You get a compulsion to just let that run through. Oftentimes I'd be reading books, but I would get stuck on a line or a sentence.
Like you'd be reading a sentence,
and somehow I'd feel that when I got to the end of that sentence, I hadn't really taken it in. I read the sentence, but then I thought, well, I really didn't grasp that. I better read it again. And that process got to be pretty repetitive. I would go over things many times and couldn't feel very good about continuing on until I felt right about that particular sentence. And of course that could happen 2 or 3 times on a page. But I would go to the sink to wash my hands, and I might stand there easily for 15 minutes and wash my hands without stopping, because I would just about get through washing them, and part of my hand might touch the sink, or maybe I couldn't remember whether the towel that was laying there was clean, that I had touched or something. Maybe somebody else had touched it before I did, and you don't know why they were washing their hands.
So these thoughts would come in.
Yeah, and so I would almost get through, but then something else would happen and kind of tell me, no, it's no good, you have to start over. So I'd start over again, and by the time I left work, I had washed my hands no less than maybe an hour to an hour and a half, if you take just the time I was washing my hands during the day.
In like an 8-hour work day.
Yeah, and they would
get chapped and bleed,
and I would try and kind of hide that if I'd be walking around where there was some of the other people I work with, because they, might ask about it, and I'd have to, of course, having OCD, I think I was and am have gotten to be a master at making up excuses for doing rituals,
What other things happen to you when you're manic besides you can't stop talking?
Well, what I found out what I could do, since usually by my manicking and talking to people constantly, I had to get something out of that way and go some other direction, because all I did was get people angry at me.
People would get angry because you talked all the time.
Yeah, so what I did, you see, the only time I ever talk a lot is when I'm sitting down talking with you or somebody else.
Okay.
And sometimes it wouldn't make any sense anyway.
So would you kind of lose track of what you were thinking when you get that way?
Yeah, but not that often. Usually unless I was in a depressed state in that matter.
Yeah. Sometimes
what I've found out to do, because you asked me what would I do in the sidetrack would be, is I started working.
So would you work long hours?
I'd work long hours, 22 hours a day.
22 hours.
Yeah.
For how long would that go on?
Well, I was assistant manager of a mobile home park down in Tucson, Arizona, and I was assistant manager and maintenance man.
So you'd work 22 hours a day?
18 mobile homes out there, and one of them was mine. And I started off at 4:30 in the morning and didn't quit until 2:30 the next morning.
How many days would that go on?
Well, that would go on for, let's see here, I worked for 10 and a half months, and what I did was I went to a complete total exhaustion.
Yeah. So how long would it take you to get totally exhausted doing that?
10 and a half months.
You went 22 hours a day for 10 and a half months?
No, because there were some spans of 3 or 4 days I would never even sleep.
Did you feel like you had extraordinary powers when you were in that state?
Well, I could say that I had powers to where I could ask the Heavenly Father for certain matters.
Special relationship?
In fact, I will share with you one. Last month, on the 16th, and August 16th, when I came down with a big federal escort from San Francisco because I'm getting ready to turn a Senator Dennis DeConcini in for undercover narcotic, for his sales of narcotics, prostitution, and illegal firearms, as well as illegal aliens coming into the United States called Mexicans, and the contract on my head for that. But
what were the special powers you got involved with?
The special power that I had was everything I lost, so I got a taxi. I had $40 in my pocket, and I had him drive me up to the Catalina Mountains, as close as he could get to it, which was not very far. So then from there, I got out of the cab, I paid the cab driver, and I said, now you get this letter to the prosecuting attorney for the state. And you give this letter to him immediately, because I'm going and I'm going to see my people, the people that I have been laying my life down for all the time. I was talking about my Heavenly Father. And I climbed it up through the ravine and scaled some cliffs. I didn't even have, I was on full faith of the Heavenly Father, because in lieu of the matter, I'm scaling cliff without the proper boots, without a life rope, and without a life belt. Nobody underneath me except for the cliff, and nothing above, but just keep on climbing. I did know, very dangerous. In fact, if I couldn't have come down that mountain, that would have been suicide. I received a lottery ticket out of the United States for $240 million, and I was calling in financial organizations of where I could go and invest these monies, so that it would be like a double or triple profit, and at the same time be able to use these monies to help the needy.
How much money did you receive?
Well, the lottery ticket was worth $240 million. It was from the Canadian lottery, which you can win up to $700 million.
And did you win it?
Well, actually it was sent to me from somebody from BC. British Columbia or Washington, D.C. sent me the ticket, and I put it in a Bible, and that Bible and I and my first fan that I had in Tucson, Arizona, the Bible went with the van, as I had been very badly assaulted and dropped out in the desert for dead. I came out of the desert with every bone broken in my body, except for one, which was this one right here, which was my CP over the cross, which only stands for Christ power or Christian power. And that was the only bone that had not been fractured or broken.
One of the things you want to be aware of when we're talking about administering medications to modulate the function of the nervous system is something called the blood-brain barrier. This prevents or slows down the passages of chemicals and pathogens from the blood into the central nervous system. It's made up of walls of capillaries in the central nervous system that surround most of those tissues, and also part of the barrier is formed by the glial membrane. Remember that the glial cells are essentially the housekeeping cells for the central nervous system. They perform functions such as insulation, protection, the acquisition of nourishment, and um, they also give some structure to the tissue of the central nervous system. It's important to remember because some beneficial drugs don't easily pass through this barrier. These will be drugs that tend to be polar in nature. Drugs that are lipid soluble can pass through this barrier with relative ease. That's why anesthetics and alcohol don't have a difficult time making it into the tissue of the central nervous system. The same can be said of steroid hormones. They, due to their nonpolar nature, don't see cell membranes as a major barrier, and so they can easily pass through them directly into the nervous tissue and wield their effects. Because of this, the tissue of the central nervous system exhibits a characteristic we call immune privilege, which means that there's no fear of tissue rejection with transplanted tissue introduced into the brain, because the formed elements of blood, particularly the white blood cells that mediate the immune response, are incapable of passing through this barrier, and so they can't mediate the phenomenon of rejection. So, with that in mind, most drugs that are effective at treating central nervous system disorders tend to be those that have a nonpolar chemical character to them, or largely nonpolar. Medications can affect chemical synaptic transmission in many ways. Some medicines bind to neurotransmitter receptors and mimic effects of that neurotransmitter, such as nicotine and tobacco, or opiates, which have a pain relieving effect. Examples of opiates would include morphine, opium, cocaine. They all have a similar molecular shape, and they bind the same type of receptor called the opioid receptor in the brain, and this produces an analgesic effect. L-DOPA can be administered for Parkinson's, and again, it mimics dopamine as a neurotransmitter. And there are also benzodiazepines. Valium is an example of a benzodiazepine, and they tend to have an effect on neurotransmission in which they cause certain neurotransmitters to sit longer in the synaptic cleft than they otherwise would. So all of these have some sort of neurotransmitter mimicking effect. Okay. Some medicines stop removal of neurotransmitters from synapse. As a result, this prolongs the activity of the neurotransmitters. Examples would be MAO inhibitors, such as selegiline for Parkinson's, or SSRIs like Prozac for depression. And what these do is they decrease the breakdown of the neurotransmitter in the cleft, and as a result of its remaining in the cleft for a longer period of time, the signal that it produces on the downstream target lasts for a longer period than it otherwise would. There are also acetylcholinesterase inhibitors, such as neostigmine for myasthenia gravis or Aricept, that's been used for Alzheimer's. Some medications do the reverse. They block neurotransmitter receptors and prevent the activity of certain neurotransmitters, such as acetylcholine receptor blockers, such as scopolamine for motion sickness, and succinylcholine, which is a muscle relaxant, and beta blockers, which block norepinephrine receptors, like elapressor for cardiac problems. Other neurological conditions we want to touch on: carpal tunnel, something you've probably all heard of. It's an inflammation and swelling of the tendon sheath surrounding the flexor tendon of the palm. This is the flexor retinaculum. You would find it just proximal to the carpals, and what essentially happens is through repetitive movement you cause an inflammation of tissue that presses on the ulnar nerve. Examples of this repetitive motion would be typing on a keyboard. As a result of this inflammation, the median nerve is compressed. This produces tingling and sensation or numbness of the palm and the first three fingers. So, where have we been so far this term? This is our first chapter. I admit that it's a rather long one. It is probably the most extensive chapter in your textbook, but a lot of valuable information was covered. The nervous system, remember, is the body's information superhighway. It's made up of two anatomical divisions, the central and peripheral nervous system. Remember that information comes into the peripheral nervous system and enters the central nervous system through the dorsal root into the spinal cord, up to the brain stem, and then to the brain. The reverse flow of information are commands that are generated in the cerebral cortex, sent down to the brain stem, to the spinal cord, where they exit then the ventral root, the part in the front, to the peripheral nervous system, and then from there all the way to the effectors. The nervous system is made up of two types of tissues, two types of cells. Neurons send and receive electrical information, and the glia provides support and protection for the neurons. Neurons are said to be excitable cells in that they carry tiny electrical currents which are caused by changes in cell permeability to certain ions. The main one, the initiator, usually is calcium. These tiny electrical currents can be all or none, as in the case of action potentials, which initiate at the axon hillock and propagate all the way to the end of the axon where they reach the synaptic bouton and cause the release of neurotransmitters. Or they can change depending on the size of the stimulus and the distance from that stimulus, and those are called local potentials, and we see those primarily in the soma of the neuron, the cell body. They travel down the axon if the action potential is going to be fired. Once we begin that series of events, we cannot stop it. This is what's termed impulse conduction. It can also be used to transmit information from one cell to another through chemical gaps called synapses, through which neurotransmitters move the electrical signal. The central nervous system is made up of the brain and spinal cord. It is surrounded by a three-layer membrane system made up of the dura mater, the pia mater, and the arachnoid. Cerebral spinal fluid is also contained between the arachnoid and the pia mater. Collectively, the pia, dura, and arachnoid are known as the meninges. Meningitis is an inflammation of these protective membranes. The spinal cord has 31 segments, each a pair of spinal nerves. Spinal nerves are a part of the peripheral nervous system and made of a pair of spinal roots. The ventral root is how motor information leaves the central nervous system to the peripheral nerves and then the effector. And the dorsal root is the main highway for sensory information to enter the central nervous system from the peripheral nervous system up to the brain stem and then to the brain. Spinal nerves are mixed. They can carry both sensory and motor function. The reason for this is the insulation that's present inside nerves due both to the glial cells that insulate the axon proper and the connective tissue that is found in between bundles of neurons. So information can flow in either direction in a nerve. Remember that a nerve is a much larger anatomical structure than a neuron. Okay, a series of tracts run up and down the spinal cord to and from the brain. Tracts going towards the brain carry sensory information to it, and tracts coming from the brain to the spinal cord carry motor information out. The brain is a hierarchical organ. It's got several lobes that contain various functions. Nerves attached to the brain are called cranial nerves, which occur in 12 pairs, and these nerves can be either sensory, motor, or mixed. The cerebrum controls conscious movement and sensation. It is a coordinator of sensory input related to intended actions, and it compares them to the actions that are being performed. And so if those don't sync up, the cerebrum will act to change what you're doing so that what you intend to do is also what you're perceiving that you're doing. Beneath the cerebrum are the diencephalon, the brainstem, and the cerebellum. Um, each part plays an important role in coordinating sensory and motor information for the cerebrum. Remember um, that the cerebellum is that little hunk of neural tissue that looks sort of like turkey burger. It lies posteriorly and inferior to the occipital lobe of the brain, and it also has a role in coordinating your sensory and your motor function and getting them to sync up. The cerebral cortex contains both motor and sensory maps of the body. Orders for voluntary movement originate in the primary motor cortex. They're located in the precentral gyrus of the frontal lobe, and they travel down the spinal cord through direct spinal cord tracts. Subcortical structures, those will be um, tissues beneath the cerebral cortex, coordinate this information through indirect tracts. Somatic sensory cortex is in the postcentral gyrus of the parietal lobe, and the sensory information from spinal cord tracts eventually ends up in this part of the brain, the very uh, superficial most portion that is just behind the central sulcus. When information arrives there, you become aware of the sensation. Other parts of your brain, called association areas, let you make connections between these sensations and something that the brain can categorize them into, whether it be sound or sight or touch or tickle or whatever the sensation happens to be. Remember that the brain is very modular in the way it does things, and the association area literally attaches this information to the stimulus so that then your conscious mind can understand it. Ventricles are cavities in the brain. The spinal cord cavity is called the central canal, and these cavities are part of an elaborate protection system for the central nervous system and are filled with CSF, cerebrospinal fluid. The nervous system also controls involuntary movement through the autonomic nervous system, and this system is split up into two functional divisions, the sympathetic and the parasympathetic division. The sympathetic division controls our freak out response. Basically, it allows you to produce physiological change that will make you better able to either flee or fight a particular event, a particular challenge to your well-being. Parasympathetic division of the autonomic nervous system has the opposite effect. It is what we would call our rest and digest division. It's primarily involved in GI motility and non-emergency innervation of glandular tissue, muscular tissue, and physiological responses. The nervous system can have many disorders. Most are chronic, progressive, and incurable. Symptoms vary depending on the location of the damage. Symptoms typically do not vary depending on whether the disorder is central or peripheral, genetic, or caused by disease or trauma. Muscle weakness, loss of sensation, and respiratory difficulty often accompany problems in the nervous system. Subtle differences between symptoms are the key to making difficult diagnoses and finding appropriate treatment. Treatment generally consists of symptom management and the prevention of further deterioration. And we have a few case studies here. There's a gentleman named Ray. This is the young man who hit his chin on the bottom of the swimming pool doing a backflip. What happened? He jammed and twisted his neck. He broke it. The first two vertebrae are shattered, and his spinal cord is irreversibly damaged. He's paralyzed from the neck down, and he's dependent on a ventilator to breathe. Muscle weakness, loss of sensation, and respiratory difficulty often accompany problems in the nervous system. Subtle differences between symptoms are the key to making difficult diagnoses and finding appropriate treatment, which generally consists of symptom management and the prevention of further deterioration. What is the level of Ray's injury? Well, it's cervical, right? Because we know that it's the vertebrae in the neck that were affected. Why can't he breathe? Well, the reason for this is that the respiratory centers of the brain lie primarily in the brain stem, particularly the hypothalamus controls respiratory rate, And if we cannot send that information from the hypothalamus to the brainstem down the spinal cord to the target, in this case the diaphragm, then we're going to have great difficulty in producing voluntary movement of that muscle. Remember that the cervical plexus is the primary area through which we innervate the diaphragm. Remember C345, keep the diaphragm alive. In Ray's case, what we have is a disconnect between those plexi and the diaphragm. So he's unable to voluntarily innervate his muscles, so he has to be in a breathing assisted situation. What do you call paralysis of all four limbs? That is a quadriplegic individual. And what complications might be a problem for Ray? Anything that has to do with spinal cord reflexes. These include urination, defecation, breathing, all these things. And so Ray is going to have to be tended to. He's incapable of movement, so he's going to have to be turned in order to avoid pressure sores because he cannot initiate voluntary movement. He'll have to be changed, and he'll have to be on a ventilator for the rest of his life. Ray has what we would call flaccid paralysis, where we have essentially no response of the muscular tissue as a result of innervation. So this is not a good situation. All right, I will see everybody in class this week, and we will pick up with the endocrine system. Thank you.